This week we're talking about diabetes and metabolic problems, so I thought I would go ahead with this little lecture, and I'll try to keep it as brief as I can without taking anything away from the importance. So we can pretty much skip this slide. You know that the pancreas has alpha cells and beta cells, and the beta cells are the ones that produce insulin. And insulin is important because in order for sugar to get into any cell, with one exception, some specialized neurons can get sugar into the cell without insulin, but the rest of the cells in the body require insulin to get it in. In this animal model where they took out the pancreas, you can see that when they give sugar, it just builds up in the bloodstream, but none of it really goes in to the cells. The intracellular glucose concentration doesn't really change without insulin. Once insulin goes in, then the intracellular glucose level can go up as the extracellular glucose level goes up as well. So when insulin is given or secreted, insulin attaches to the cell membrane through a specialized location, and that receptor opens up a couple of things. One, of course, it opens up a channel where glucose can go in and participate in all this stuff, right? But it also, as you may remember from being a critical care nurse, when we give insulin, it also forces potassium into cells. Not only potassium, but also phosphate and magnesium. And the thing that we don't really know about as nurses or talk about is that it also lets in amino acids for protein synthesis in the cytoplasm. So there are lots and lots of new drugs on the market that target different physiologic mechanisms, and I thought it was a good idea to review some of these. So in a generic sense, we have glucose transporter receptors. They're called GLUT receptors, and they're all over the body in different cells. And last time I think that I looked anyway, there were something like 15 different glucose transporter receptors in the body. A couple of the important ones, GLUT2 is present in kidney cells, and GLUT3 is what crosses into the placenta, and GLUT4 is mostly in adipose tissue and muscle tissue. Just for reference, I wanted to go over those. But the really important thing that I want you to know about is this, and this. So the sodium glucose transport 2 protein, or the SGLT2 protein, we've known about this for a long time, but I don't know, 10 or 15 years ago, the pharmaceutical industry released the flozins, right? Empagliflozin and some of the other flozin drugs that focus on this particular protein. This is huge. It's huge. It's pretty good for helping control blood sugar, and it's nice because it doesn't lower the blood sugar and make you hypoglycemic. But it's really good for heart failure, which is why I get excited about it, right? So these SGLT2 proteins normally function to preserve the organism, right? They make the kidney hold on to sodium. Why do you need to do that? Well, because when we were getting attacked by saber-toothed tigers many years ago, we would bleed to death, and we needed sodium to maintain our fluid balance so we wouldn't be hypotensive, right? So sodium helped to, reabsorption of sodium helped to preserve the species, and also we needed energy, right? So the kidney learned to use this mechanism to keep glucose in the bloodstream, again, to preserve the organism. Today, we don't die from saber-toothed tiger attacks, we die from diabetes. So we can target these and have good outcomes. Another commonly seen drug class focuses on the GLP-1 or the incretin hormones. And what this does is it enhances insulin release in the postprandial state. That's the key to it. Because we have drugs, we have the secretagogues that squeeze the pancreas. Think of diabinase and glucotrol and those kind of old-fashioned drugs. They squeeze the pancreas and get insulin out, but indiscriminately, right? It just squeezes the pancreas when the medicine shows up. What we needed was a way to squeeze the pancreas when there was food that needed to be digested, when food was present, so that we can get that insulin to the cells to use that energy. That's what the GLP-1 receptor agonists are all about. And there's a sort of a backdoor method to keeping that GLP-1 incretin hormone going, and that is the DPP-4. So the normal function of the DPP-4 mechanism is to inactivate the GLP-1, right? So if we give a drug that will that will stop the DPP-4 from inactivating GLP-1, that is, give an agonist to DPP-4, then the GLP-1 mechanism continues to work. So that's another way that pharmacologists have been able to do this. Now, there are some DPP-4 isolates. The DPP-4I has shown, the DPP-4 inhibitors, that's what the I stands for, has shown promise in reducing graft versus host disease in stem cell transplants. So some of these mechanisms are going to become more and more important in broader and broader arenas as we move forward. So keep an eye on them for further developments. So as I said earlier, glut proteins are everywhere. They're in the gut, they're in the heart, they're in the kidneys, they're all over the place. The GLUT1 or the SGLT1 receptors happen to be in the gut, all right? And they work on the gut in order to reabsorb sodium and glucose. Just like in the kidney, which we'll see next, these GLUT receptors work in the gut to reabsorb or to absorb sodium and glucose and galactose and fructose and all these other ones. But the SGLT1 receptors work here. They move the sodium and glucose through the brush border into the cells of the gut, and then the GLUT2 put sugar, galactose, and fructose into the interstitial space. The only reason I'm mentioning this is because the next class of drugs that comes out is going to be the SGLT1 receptor blockers, which will probably be combined with the SGLT2 receptor blockers and could show some really exciting effects in diabetes and also in heart failure if the SGLT2 studies are any indication of that. So again, back to the SGLT2, this happens in the kidneys. So here we have the proximal tubule, and you remember that in the distal convoluted tubule, all of these substances move in and out. In the loop of Henle, a couple of substances move in and out, principally sodium and water. But in the proximal tubule, this is where essentially the plasma, minus the big proteins, go from the glomerulus to be distributed in the kidney. And one of the big things that happens there is the SGLT2 receptors, or the SGLT2 protein, takes sodium and water and glucose out of the filtrate, right? Out of the filtrate, and moves it into the cell so that it can be sent into the bloodstream. Again, the purpose of this mechanism is to preserve the organism. We want to keep sodium because with sodium comes water, so we can maintain a blood pressure if we get attacked by a saber-toothed tiger. And we need glucose because we have to go hunting and kill mastodons and all sorts of things in order to survive as cavemen. And so this mechanism worked to help preserve the organism. Today, it's become a target because now we die from diabetes and heart disease, right? So, when we're thinking about diabetes, I want you to always keep in mind this scenario. And we all have seen it, taking care of patients. A woman with diabetes is in the hospital. She goes to bed with a fasting blood sugar of 110, has nothing to eat or drink overnight, no calories in, and the next morning, she wakes up with a blood sugar of 200. How in the world does that happen? Well, don't forget that the 3 ways that you can get blood sugar into you are from dietary intake. Now, this person didn't eat anything, so that's not what's causing the increase in the blood sugar. But also, when your body needs it, if there's no dietary intake of calories, it can do glycogenolysis. It can break down glycogen, which is just a big ball full of glucose, and it can distribute that glucose in the glycogen for use by the cells. So that's the second way. The third way then, if you have depleted your glycogen stores, is your body can break down fat and protein in order to produce blood sugar. So those are the 3 ways that our bodies can produce blood sugar. So how do we monitor an average blood sugar over a period of time? Well, we use the hemoglobin A1C. And remember that hemoglobin A1C is a function of the amount of sugar that sticks to the red blood cell. Red blood cells live for 3 to 4 months. And so this is the method that we use to indicate blood sugar control over that 3-month period. Okay? And what does that result mean? Well, we know that a 1% change in an A1C reflects a change of about 30 milligrams per deciliter in average blood sugar. And so if you look at this table on the right, you can see that an A1C of 6%, second row there, represents an average blood sugar of 100 to 152, and the mean of that is 126, which, by the way, just happens to be the magic number for making the diagnosis of diabetes. When we are dealing with diabetes, the first thing that we have to do is make the diagnosis, right? And in order to do that, we have to understand the different types of diabetes. Everybody knows that autoimmune destruction of beta cells is type 1 diabetes. Type 2 diabetes is a progressive loss of beta cell function and concomitant insulin resistance. There's not enough blood sugar getting into cells because the cells are resistant to that insulin. Even if the insulin levels are high, there's a resistance to them getting in. There is this thing called type 1C diabetes. You may remember this from Patho. We talked about it briefly there. This is a type of diabetes that essentially is from a burned out pancreas. Now that can happen because of neonatal causes. It can happen because of cystic fibrosis, chronic pancreatitis. There's lots of things that can do this. We rarely see it. I personally have never seen this problem that I know of, but it is a possibility, and you may encounter it from time to time in clinical practice. Finally is gestational diabetes. We used to think that if you got gestational diabetes that was just because of pregnancy and you'll be fine. We know now that that having gestational diabetes dramatically increases your risk of developing type 2 diabetes within the next 5 years. And I don't remember what the number is, but it seems to me it's around 30 to 50%. If you have gestational diabetes, I think you have a 30 to 50% risk of developing type 2 diabetes in the next 5 years. You'll see down here in the lower right corner, the ADA. You can click on that, and that will take you to the latest guidelines from the American Diabetes Association, which were published, I think, in May of this year, of 2022, that is. All right, so type 1 diabetes, autoimmune. If you care to know this, one way that we can see whether someone is type 1 or type 2 diabetes is by measuring the amount of C-peptide. C-peptide comes from, it's a leftover, it's a product of insulin production in the patient's pancreas. And so when the insulin is produced, it comes out in this big long chain called proinsulin, and then we cleave off, our bodies cleave off the A and the B chains, and that leaves us with this C chain. And that C chain is inactive, it's inert, it doesn't do anything, but we can measure it as a function of how much insulin our bodies are producing. So in type 2 diabetics, they'll have preserved or even elevated C-peptide levels. In type 1 diabetics, at the beginning, they will still have C-peptide. As time goes on, they will have less and less C-peptide, and endocrinologists can use this to sort of gauge their loss of beta cell functionality. There was something else I was going to say about that, and it escapes me right now. The reason that we can do this in people who are getting insulin injections is that the insulin that is produced does not have C-peptide. It just has the insulin molecules. There's no C-peptide in exogenous insulin. So that's how we can do it. All right, type 2 diabetes, the obesity, poor diet, inactivity, those things increase your risk of developing type 2 diabetes because insulin resistance is part of that. Now let's talk briefly about insulin resistance. We know that we can reduce insulin resistance by having patients exercise daily, right? And you don't have to be a marathon runner. You just have to get off your butt and go out and walk, right? That's all there is to it. Or swim or some other activity that you enjoy. And the way I like to think about this, the model that I use in my head is that when we exercise, we deplete the glycogen stores in muscle and in liver, because our muscles during exercise need all that energy. So we deplete that glycogen store, and then after exercise, there's room for your body to refill those glycogen stores. And that is part of why exercise is so important, and it's part of reducing insulin resistance. Now, it's not the whole story. There's more to it than that, but that's a good model for thinking about it, and it makes it easy to explain to patients why daily exercise is important as well. Okay, so type 2 diabetes, it's far more common than type 1 diabetes. 9 out of 10 patients who we see with diabetes have type 2. The risk factors are metabolic syndrome, central obesity, dyslipidemia, prehypertension and hypertension. We know all those things, right? It can affect men or women, can affect children as well as adults. Gestational diabetes, we talked about already, increases your risk. So let's talk about the ADA guidelines for 2022 that focus on screening. So screening should be considered in adults who are overweight or obese, and who have one or more of the following risk factors. So first degree relative with diabetes. Remember, first degree relatives are mother, father, brothers, sisters, or children. Okay? Grandparents don't count. Aunt Mabel doesn't count. My best friend's cousin's uncle's roommate doesn't count. Mother, father, brothers, sisters, and children. Those are primary relatives. High risk race or ethnicity, so African Americans, Latinos, Native Americans, Asian Americans, and Pacific Islanders. People who have a history of cardiovascular disease, people with hypertension, people with low HDL or elevated triglycerides. And the reason for that is diabetes often causes a dysmetabolic syndrome that features hypertriglyceridemia and low HDL. So it may be that the low HDL, high triglycerides are a cause of diabetes, and that's why we should test for it. Women with polycystic ovary disease, people who are physically inactive, and other insulin-resistant conditions like severe obesity. Okay? Patients with prediabetes should be tested yearly. Women who had gestational diabetes should be tested at least every 3 years. All other patients should be tested at age 35 and periodically after that. And then if results are normal, you should test them every 3 years. The criteria for calling somebody pre-diabetic is a fasting blood sugar of 100 to 125. So anytime we find a elevated fasting blood sugar, and fasting means after 8 hours of fasting, then we should label these people pre-diabetic and start aggressive interventions, diet, exercise, all that, right? And we'll talk about other things next. If they have a 2-hour blood sugar drawn after a 75-gram oral glucose tolerance test and have a result of 140 to 199, that's prediabetes. And if they have an A1C of 5.7 to 6.4, that's prediabetes too. So those are the criteria for making the diagnosis of prediabetes, which is important because we can intervene and hold off diabetes or prevent it altogether. So let's talk about treatment. I have slides in here that are from up to date that I looked at last year, and other slides that are labeled ADA 2022 are from the latest guidelines. So for prediabetes, we really like metformin. It's a cuddly drug, right? Very cuddly drug. It does very few things that are bad. It may be a super medicine that helps with aging. It's similar to, but not a replacement for, exercise in the physiologic effects that it has. And it's just a cuddly drug, right? It's a very good drug for patients with prediabetes and diabetes. So people who are age 25 to 59 with a BMI that's high, if they have higher fasting plasma glucose, more than 110, if they have a higher A1C, usually over 6, or women with prior gestational diabetes. All of those people should be considered for metformin therapy. Metformin can cause vitamin B12 deficiency, and this is even a higher incidence in people who've had bariatric surgery, especially the Roux-en-Y or the biliary diversion surgery. So make sure that you're taking a good history about those things. Also, if somebody is on metformin and they have anemia or peripheral neuropathy, those can be associated with vitamin B12 deficiency as well. So make sure that you look into that. And don't forget that prediabetes is associated with a higher risk of cardiovascular disease. So screening for all of those things is important. It's interesting that the ADA now has named a level of weight loss that is desirable for lifestyle intervention. When people lose weight, if they lose 5 pounds, that's great, terrific, but it may not be sufficient to reduce their risk. So the ADA has looked at the studies, and it turns out that about a 7% total weight loss is the number that they're looking for. 150 minutes of moderate exercise weekly is what's recommended for pre-diabetes. Earlier studies of diabetics have shown that daily exercise is the best, but at this level, we're trying to get people to do something, right? And in terms of doing something, that also applies to diet. The new guidelines say essentially whatever diet works for you. If you like the all carbohydrate, all fruit and vegetable diet, no plant or all plant-based stuff, do it. If you're successful with it and you can stick to that, do it. If you are an Atkins kind of person and you want to eat all beef, do it. Get the weight off, reduce your risk however you can do it. That is the current recommendation. I may have stretched that a little bit. I'm sure they wouldn't love people eating steak every day, but again, some people find that easier to do, and it's the weight loss that we're looking for. And getting rid of carbs has never been a bad idea. The macronutrient, well, that's just more information that I already shared. So whatever eating patterns can get you to goal is what we're looking for. And then, of course, we want to screen and treat modifiable risk factors. As I tell patients in my practice, we don't care what your cholesterol is. We just want it lower, right? And we want your cholesterol to be perfect. We want your blood pressure perfect. We want your blood sugar perfect. We don't want you smoking. We can't change your parents, and we can't change your age, but the other risk factors we can. So let's do that together. Here are the criteria for the diagnosis of diabetes. So the magic number is a fasting blood sugar of 126. And again, fasting means no caloric intake for 8 hours. The other way that you can make the diagnosis is with a 2-hour postprandial oral glucose test. So you draw the blood 2 hours after the 75 grams of glucose, and then we make the diagnosis based on that. Or if you have a hemoglobin A1C more than 6.5%, that is also diagnostic. And then in a patient with classic symptoms of hyperglycemia or hyperglycemic crisis, a random plasma glucose of over 200 is also diagnostic for diabetes. So what are the goals of diabetes treatment? Well, we want to manage their glycemic effects to prevent microvascular and macrovascular events. And we know from the UK PDS trial I forget when that came out, in the early 90s with type 1 diabetics, we know that tighter blood sugar control was beneficial. They loved this UK PDS thing. It was a groundbreaking trial, so they did a whole bunch of other ones after it. And UK PDS 33, which was published in 1998, showed that intensive glycemic control for type 2 diabetes matters too. And we had terrific improvement in outcomes when we treated the hemoglobin A1C to less than 7%. Now, do we stop at 7% now? No. Sometimes we want tighter control. On the left side of this image are the people who we want to be more stringent with, the ones whose blood sugar we want to control more aggressively. So patients who are newly diagnosed, who have a long life expectancy, right? If you're 25, we don't want to keep your hemoglobin A1C around 8. We want to keep it near perfect, right? Because you have a long time to go where that diabetes can affect your cardiovascular risks. So for people on the left side, we want to be more stringent with their hemoglobin A1C. People on the right side, less stringent. So an 80-year-old person with type 2 diabetes and heart disease and other problems doesn't have a long life expectancy. And so letting them have a little higher blood sugar with less risk of hypoglycemia, especially if they live alone and are frail, then that's reasonable too. So these are the criteria that are used today to make those decisions. So how do we decide when to begin treatment and how do we start with treatment? Well, we always want to make sure that patients are on an ACE or an ARB for renal protection. So renal protection, it comes from the mechanism of action of the ACE inhibitors and ARBs. If you remember your renal physiology, the glomerulus is supplied by the afferent arteriole, right, that takes blood to the glomerulus. And then the efferent arteriole takes blood away from the glomerulus and goes around the proximal tubule, the loop of Henle, the distal tubule, etc. So when we give an ACE inhibitor or an ARB, what we're doing is vasodilating the afferent arteriole. And what does that do? Well, it takes pressure off of the glomerulus. And the benefit to that is it improves outcomes because it lessens the stress on that glomerulus, reduces protein leaking out through the glomerulus, and leads to better cardiovascular and renal outcomes. So we love ACE inhibitors and ARBs. Remember, when you start them, you may see an increase. You may see an increase in the creatinine. That's okay, as long as it's not 3, right? And as long as they don't have hyperkalemia, that's okay. That's how it works. We expect to see an elevation of the creatinine, slightly, and not dramatic increases. Certainly not anything that is in the neighborhood of, more than 0.5 to 1. Okay? When we start with therapy, we start with metformin. It's cheap, it's effective, it's a cuddly drug. It improves insulin resistance, reduces hepatic glucose production, and reduces glucose absorption from the gut. These are the 3 ways that this drug works, and we love each and every one of those things. We also love the fact that it does not cause hypoglycemia. That's perfect. We don't want hypoglycemia. Hypoglycemia is deadly. We don't want that. Now, the way we do this is we start low and go slow. So for diabetes, the starting dose is 500 milligrams once a day with meals. Then you increase by 500 milligrams per week until you get up to a 2-gram total daily dose in divided doses. For pre-diabetes, it's different. You can start 850 in the morning and then add 850 at night, and that's sufficient for pre-diabetes. So this image is from the ADA guidelines, and it's a little busy, but see if I can take you through it. At the top, we're talking about first-line therapy, and that's dependent on the comorbidities, the patient factors, whether they can manage a more complex method, and cost is huge, right? Some of these SGLT2 inhibitors are gazillions of dollars and very hard to afford. The next thing that we take into account is their cardiovascular health. Do they have cardiovascular disease? Are they at high risk? Do they have heart failure, hypertension, CKD, those kind of things? And then based on their comorbid conditions, we can pick the next drug to add, whether it's a GLP-1 receptor agonist, which has cardiovascular outcomes data, very cuddly drugs, we like them, or an SGLT2 inhibitor, which also has proven cardiovascular outcomes data, but we kind of like it more for the hypertensive people, and also for the heart failure people, which is the next column there. SGLT2 definitely for people with heart failure, whether it's systolic or diastolic heart failure. These SGLT2 inhibitors are such a blessing for cardiologists, because now we finally have something that helps everybody with diastolic heart failure. All right, and then when there's CKD, we like SGLT2 inhibitors, but we have to be careful, because once you get down below a GFR of 30, you can't start most of the flozins, most of the SGLT2 inhibitors. So there's special rules about starting them and continuing them, and I'm not going to go into those things today, but they're important to look at. All right. We also like the GLP-1 receptor agonists for patients who have slightly lower GFRs. But again, there's limitations on using those agents in those people. So take a look at this table. I can't go through everything individually, but this is a good guideline to use. Now let's talk about acute care NPs and what you need to know. We need to think about how we're going to start insulin therapy in the hospital. We use insulin for severe hyperglycemia, especially if they're symptomatic or catabolic. Catabolic means they're losing weight, right? A very easy way to do this, and a safe and effective way, is to use basal insulin. Basal insulin has much easier patient satisfaction and just about the same glycemic control. So it's a cuddly method for starting insulin. You can just give a basal dose and let somebody else worry about it later on. Very good thing to do. Very convenient for us in the hospital. This comes from Up to Date. You can see what the latest recommendations are, but essentially this gives you the criteria that you'll follow when you start insulin, how many units per kilogram, how to go up, how to be influenced by the hemoglobin A1C, etc. So the anti-diabetic drugs that are in red here are the ones that we love today. We love metformin just because it's easy and it's cuddly. It has 3 great mechanisms of action. Remember what they are. It improves insulin resistance, reduces liver production of glucose, and it reduces GI uptake of glucose as well. So those are 3 very cuddly mechanisms. It doesn't make people hypoglycemic, so that's also good. There's no outcomes data with metformin that I know of. But these other 2 do have outcomes data. GLP-1 agonists like Victoza, and the SGLT2 inhibitors, which you're probably sick of me talking about. Okay? So the other ones can be useful. Glucotrol, the sulfonylureas, the secretagogues, they can be useful, but we tend to favor the GLP-1 agonists now over the sulfonylureas, again, because the GLP-1 agonists stimulate pancreatic release in the postprandial state, which is when you need it. Okay? The other ones up here, we don't really use that much. Precose makes everybody have gas and it's uncomfortable, and you take it with the first bite of food to reduce the blood sugar. It's nice because it doesn't make you hypoglycemic. It's annoying because it makes you pass gas all the time. Nobody likes that. The DPP-4 inhibitors, they're also expensive. Victoza, Januvia, Jardiance, they're all very expensive. So we may have trouble getting those paid for. But then, of course, never forget about insulin. It's usually cheap and effective. The most important thing that you can share with patients when they're starting on this diabetes journey, and it is a journey, is the relative benefit of exercise in lowering their A1C over all the other options. So look at the first line there that says lifestyle change to decrease weight and increase activity. You get the most bang for your buck from that. You get a 1 to 2% reduction in the hemoglobin A1C. I should say a 1 to 2 point reduction. That's incredible. That's incredible. Hard to do, hard to get people to do that, but that is the best way to do it. The second best way to do it, you get the equal benefit from metformin. It's fantastic. Doesn't necessarily make you lose weight. It may help you lose weight. And there are some limitations with renal function, of course. But look at a magic drug like an SGLT2 inhibitor. You only get 0.5 to 0.7 point reduction with an SGLT2 inhibitor. With a GLP-1 inhibitor, it may be a little more powerful. You might get up to 1.5 point reduction, but most of these things, you don't get nearly what you get from lifestyle and metformin. So keep that in mind. The mechanisms of action are sort of briefly demonstrated here. You see metformin has an effect in the upper left corner there on muscle, again, because of the storage of glycogen, and it also has an effect on decreasing gluconeogenesis, which is showed at the liver picture, and metformin also is effective in the gut by decreasing glucose absorption. This may help you to think about how some of these drugs really work. This table shows the efficacy of each of the drugs compared with the rate or the risk of hypoglycemia, the weight change that can happen, cardiovascular outcomes, cost, importantly, is the green column in the center, renal effects, and then other considerations. This is a two-part slide, so part 2 is shown on the next slide. Take a look at that and see what the relative benefits and weaknesses of some of these drugs are. This is another way to look at it, and this shows the cost of some of these drugs. So metformin is on the top line there, relatively cheap, and some of the DPP-4 inhibitors and SGLT2 drugs much more expensive. That's also a two-part slide, just so you can read it. You know, the acute complications of diabetes are either DKA or HHNK. And so let's take a look at those briefly. Remember that we really don't like hyperglycemia because over a period of time, of decades, it can cause cardiovascular disease and death and all that. That's bad. We don't want that. But we really loathe hypoglycemia because it kills you right now, right? Type 1 diabetics, particularly ones who live alone, are terrified of not waking up in the morning. Imagine if the only thing that's keeping you alive is a little device that has to be accurate enough to dose your insulin correctly and deliver it the right way. It's pretty terrifying. What if you make a mistake? You might not wake up. So hypoglycemia is really bad. We don't want to get patients into that. It's very frustrating. All right, so DKA versus HHS, essentially the difference here is the presence of some endogenous insulin. So when a type 1 diabetic who does not make their own insulin gets sick, that starts this process where they begin having lipolysis, which leads to hyperglycemia. Then they develop ketones in the urine because they're using anaerobic metabolism methods. And that leads to this diabetic ketoacidosis. When we see this in type 1 diabetics, their blood sugars are typically kind of modest. I mean, they're high, but they're not anywhere like they are in HHNK. People with type 1 diabetes often end up with, when they get sick, they end up usually with DKA with a blood sugar, 250 to 400, somewhere around there. Rarely is it over 600. With HHS or HHNK, which is hyperosmolar, hyperglycemic, non-ketotic acidosis, these patients have a little bit of circulating insulin that kind of keeps them going, right? There's enough insulin circulating that they can still meet their body's minimal metabolic demands, but it increases the blood sugar. When the kidney senses increased blood sugar, it gets rid of glucose along with water, right? And then that increases the concentration of glucose, which sends more water out the kidney, and that cycle results in super high blood sugar values and really, really dehydrated patients who are hypotensive and very sick. And that's the difference. It's really the fact that there's a little bit of insulin circulating in the HHS people that allows them to keep functioning, keep their cells functioning in a normal way, and that allows the sugar to rise, which forces more urine out, which increases the concentration of the glucose in the blood, which forces more water out, and that everlasting cycle continues until these people get blood sugars of 1,000, 1,200. I mean, it's ridiculous. So the treatment for any of these people is immediate identification, right? Knowing that people who have acute illness, trauma, surgery, MI, infection, any of those kind of things will potentially mess up their glucose balance and put them at risk for diabetic ketoacidosis. When they show up, they have laboratory values of glucose more than 250, again, up to 400, 500 maybe, rarely higher than 600 as I understand it. Their pH is low, they have ketones in the urine, and the goal there is to give them lots of fluids, replace electrolytes, use the tincture of time to allow them to get better. With HHNK, they have some insulin circulating, and that's the trick to understanding the difference. They have much more fluid deficiency. They are more dehydrated because of that hyperglycemic state and the effect on the kidneys, and the glucose levels go up much higher. So usually these glucose levels are in the 600 or more range, up to, as I said, 1,000, 1,200, something like that. And these people need tons of IV fluid, insulin infusions, electrolyte replacement, etc. This picture you probably remember from patho, talking about the causes and effects of chronic hyperglycemia. Remember, microvascular disease is one of the problems that we worry about, and the pathology is that it causes thickening of the capillary basement membrane, and that causes the disease that we see from microvascular beds. One of those is retinopathy. It's the leading cause of blindness. Make sure that patients get an annual eye check I recommend from ophthalmology, but I'll leave that up to you to decide. Diabetic nephropathy, again, all these patients should be on an ACE or an ARB. If they have an allergy, a bona fide allergy to ACE or ARB, The other way that they can have some renal protection is with mineralocorticoid receptor antagonist, the fancy name for spironolactone. That offers some renal protection as well. So remember that every single patient needs renal protection when they're diabetic. And you have to look for some other methods if they're allergic to ACE or ARB. Diabetic neuropathies, also important. We have to make sure that we are doing all that we can to protect those Schwann cells in our patients. The macrovascular complications are shown here: angiopathy, right? Coronary disease, strokes, etc. So we have to be taking care of that. Peripheral arterial disease is another function. Here's the pathophysiology of atherosclerosis. Forget this slide. I don't want to talk about that. I'm going to skip the case studies. That's really an in-class thing. And now I want to move on and talk about endocrine disorders. I think everybody's frightened about endocrine disorders because they're complex, but they don't have to be complex. And let's use the thyroid to really illustrate how the negative feedback loop works. All right. When we do that, I think it'll take away some of your concern about endocrine disorders. So remember that the endocrine system it consists of endocrine glands. Endocrine glands, by definition, secrete into the bloodstream. Exocrine glands secrete through a duct, right? So the pancreas has endocrine function and exocrine function. The endocrine function secretes insulin into the bloodstream and glucagon and other things. The exocrine pancreas secretes amylase and lipase and whatnot into the duct. The pancreatic duct, specifically. So the HPT axis is the hypothalamus, pituitary, thyroid axis. And you remember this from pathophysiology. You may be having cold sweats right now and panic. Let's just go through this. So the primary thing for you to understand is the importance of the hypothalamus, right? That's the first thing that you need to figure out. Why is the hypothalamus so important? Well, because the hypothalamus is the impact of the central nervous system. The central nervous system has to have some way to influence this whole process because, are there any reasons that we would want the brain to have an influence on production of a metabolic hormone? Well, yeah, there's lots, right? When there's fever, for instance, we're going to need more metabolic activity. So we're going to stimulate the thyroid to make more T3 and T4. Well, that center in the brain that regulates temperature is the hypothalamus. And so it has some effect on, the hypothalamus is the input to the endocrine system from the nervous system. All right. And that's really important to understand. Otherwise, we would just have the pituitary thyroid axis. But how would we be influenced? Well, it would just be a feedback between the pituitary gland and the thyroid, and it would just run its own little show without any input from anyone else. Kind of like some politicians, right? With the hypothalamus involved, we now make things more complex, right? It does get more complex, I'll grant you that. So to start the process, the hypothalamus secretes TRH, right? A releasing hormone that is taken up by the pituitary, and the pituitary senses that TRH, and it is told then to produce TSH. The TSH is produced, goes into the circulation, is picked up by the thyroid gland, and also our needles when we draw blood for TSH levels, and stimulates the thyroid to produce T3 and T4. So that's what happens. The hypothalamus says we need more T3 and T4, so I'm going to tell the pituitary. The pituitary sends a signal to the thyroid through TSH to produce more T3 and T4. But it can't just stop there, because we would end up hyperthyroid if that was the only part of it. What would be stopping the thalamus or the hypothalamus and the pituitary gland from sending out signals for more T3 and T4? There's no negative feedback loop in that scenario. So let's add that negative feedback loop. Well, what we do is we have the hypothalamus and the pituitary listening, paying attention, sensing the amount of T3 and T4 that are being released. When they sense T3 and T4, then they stop producing TRH and TSH. Make sense? Then they stop producing TRH and TSH until something else happens. What happens? The CNS, or we stop sensing enough T3 and T4, and then the hypothalamus fires up again, sending TRH and TSH to the pituitary, and then the pituitary sending TSH. So let's just use a laboratory sense of what's going on here. When the thyroid is broken, right? When the thyroid is broken, I just drew an X over that. Let's see how long it takes to pop up here. When the thyroid is broken, it's unable to respond. So the hypothalamus sends a signal, says, hey, there's not enough T3 and T4. So it sends a signal, releases TRH, gets to the anterior pituitary. The anterior pituitary says, all right, I'm going to make more TSH, and it sends TSH, but the thyroid is broken. It doesn't respond. It does not make T3 or T4. So what's the response? Well, now the hypothalamus starts yelling, and it releases higher amount of TRH, and the pituitary gland doesn't like to be yelled at, so it yells at the kid, the thyroid, and it produces more TSH, but still the thyroid isn't paying attention. So now the TSH has gone from 4 to 10. The thyroid still isn't producing T3 and T4, so now the hypothalamus is starting to get angry, and now it releases more and more TRH, and the pituitary releases more and more TSH, and now the TSH is 25, and the thyroid still isn't doing its job. And it goes on like that, so on like that forever, right? So when we see hypothyroidism, we see elevated levels of TSH because the pituitary gland is yelling at the top of its lungs at the thyroid gland. The thyroid gland is not responding. Make sense? All right. Now I'm going to change everything and explain to you that it depends, all that stuff that we just talked about with hypothyroidism depends on the thyroid being the problem. That is a primary endocrine disorder. When the thyroid, or the end organ that's producing the stuff that you want it to, when that's the problem, then we call that a primary endocrine disorder. Okay? The dysfunction is of the thyroid gland in this case. When the problem is with the pituitary or the hypothalamus, that's secondary, right? I'm not going to go into the permutations of secondary thyroid disease because it's not very common, but when we, the way to verify that it's a primary thyroid disorder is we check the TSH. When the TSH is elevated, Then you can order a reflex T4 where the lab will then automatically do the T4 level. And if the T4 level is low with the TSH high, then that's a primary thyroid disease. Okay? So that's how we do that. Glucocorticoid control is the same way, but substitute the adrenal glands for the thyroid. Again, we have the hypothalamus that starts out sending CRH, corticotropin releasing hormone. The pituitary picks up the signal and sends out ACTH, which stimulates the adrenal cortex to make the glucocorticoids, especially cortisol. That's the primary stress hormone, right? And then we have the negative feedback loop. When there's enough cortisol circulating, then the anterior pituitary stops making ACTH and the hypothalamus stops making CRH. Okay? If the adrenal glands are broken, they can't send out more cortisol. So that's when the ACTH and the CRH levels go up. That's a primary endocrine disorder of the adrenal glands. Okay? Now, take that a step further and think about what happens when we give chronic corticosteroids. Now it's all about the negative feedback loop, because now we have all this circulating corticosteroid that's telling the pituitary to stop making ACTH and telling the hypothalamus to stop making CRH. And as a result of that, you have no production by the adrenal glands of intrinsic adrenal hormones. That's why we have to wean corticosteroids, right? Now, for a day or two, you give a dose of corticosteroid, it's no big whoop. That's not going to bother anybody. But if you're on it for a period of time, you're suppressing the hypothalamus production of CRH and the pituitary production of ACTH, and you're going to have to give that time to come back. So you're going to wean those corticosteroids. Okay? All right. While we're talking about the endocrine system, I want to talk about aldosterone. I finally did it. I finally have a patient with true hyperaldo, and I've been doing this for almost 30 years. So hyperaldosteronism, remember what aldosterone does. It's part of the renin-angiotensin-aldosterone system, and it's a cool thing when we're fighting saber-toothed tigers, because aldosterone makes the kidney hold on to sodium and along with that water. Sounds like a good idea. We hold on to those things, and that keeps our blood pressure elevated. But it's a bad thing to do chronically. And that's what ends up happening in heart failure and hypertension and things like that. Our bodies produce aldosterone, make our kidneys hold on to all this fluid and water, and that can cause some bad effects. When you're hyperaldo, that further makes the problem bad, right? Because now you're really holding on to fluid and sodium. And your blood pressure really goes up. So when we have this problem, it has to be identified. And the way to identify hyperaldo or any aldosterone problems is to look at potassium in relation to the sodium. When we see an increased sodium level and a decreased potassium level, that should give you the suspicion of hyperaldosteronism. Okay? So you would round up all the usual suspects and you would get a plasma aldosterone to renin ratio. And this patient who I had had an aldosterone to renin ratio that was around 31. I think top normal was 29, so it's kind of a narrow margin there. But that meets the criteria. Then you would do some other additional testing. 24-hour urine, saline suppression test, captopril suppression test, and all that stuff. Just send them to endocrine or renal. Let them deal with it. I'm not going to get involved with that. But this guy needed really aggressive blood pressure management because his blood pressure was 1,000,000 over 1,000,000, and he was in pulmonary edema because he was retaining all this salt and water. And so what drug do you think we used? Well, we used a whole bunch of them because his blood pressure was impossible to control. But the thing that really started to bring it under better control was the anti-aldosterone drugs, shockingly, right? So we started him on spironolactone. Now he's on a pretty hefty dose. He's on 50 milligrams twice a day. And we know in men that often causes some breast tissue growth. So I would not be surprised if next time or two I see him in the office, he complains of some breast tenderness. And then we'll have to switch him to eplerenone. The difference between eplerenone and spironolactone is largely the breast tissue tenderness and price. The price of eplerenone, which has been around for 25 years, is ridiculous. It's like $400 a month. I don't know. So we don't usually use eplerenone or Inspra as a first-line drug. We usually go to spironolactone first, let the side effects happen, and then give them eplerenone if we need to. So that was an important lesson that I wanted to share with you. Here's more information about hyperaldo. Oftentimes you see hypertensive patients who have hypokalemia. That is associated with aldosterone, right? But it's not always from, in fact, it's rarely really from hyperaldo state. When you see that low potassium in hypertensives, it could be because of their crappy diet. Those of us who are built for comfort instead of speed kind of avoid the produce aisle at the grocery store and head right to the meat and ice cream sections. What foods have high amounts of of potassium, magnesium, the good stuff? Fruits and vegetables. That's where you get potassium. And so the DASH diet, which has always been shown to be effective in treating hypertension, and there was an article in Barron's a couple of weeks ago about this. Some guy just wrote an article where his blood pressure was high, so he started the DASH diet, and he actually had improvement in his blood pressure. He didn't need medicines. So don't think that hypokalemia means hyperaldo. You should check, make sure. If their blood pressure is really hard to control, I would do the testing. But we often see hypertensives with low potassium levels, and try the DASH diet. If they can eat more fruits and vegetables, that is a very effective way. And if you have trouble controlling their blood pressure, don't be afraid to add an aldosterone antagonist like spironolactone. Okay? That's a little trick up my sleeve that helps me get good blood pressure control in resistant patients, and it always amazes the family doctors. All right, lastly, I want to talk about weight loss surgery because I'm on a mission to let people know that this actually works. I want you to look at this table. This table is a mishmash of a couple of different studies that I got. I think I found it in UpToDate recently. RYGB is the Roux-en-Y gastric bypass. Not done very commonly anymore because the sleeve gastrectomy has really replaced it. But at 1 year, total percent of body weight lost is 31.2% on average. At 5 years, it's still persistent at 25%. At 25 years, at 20 years, which by the way is a different study, so we should think that this is a different line here. But at 20 years, the average weight loss kept off is 26%. Impressive, right? Look at diet and exercise. At 20 years, the chance of diet and exercise being effective, 1%. 1% body fat loss or total body weight loss. Ridiculous, right? Your chance of bariatric surgery improving your weight is about 70 to 80%. You have a 70 to 80% chance, that's not shown on this slide, a 70 to 80% chance of weight loss with bariatric surgery. Significant weight loss. Your chance of success with diet and exercise is 1%. 1%. Diet and exercise are ineffective for morbidly obese people. Do not be afraid to recommend gastric bypass or sleeve gastrectomy for patients who have been unable to lose weight on their own. Should they try diet and exercise first? Of course. Of course. Should they do diet and exercise when they have bariatric surgery? Of course. It's just like treating cholesterol or hypertension. You need to make lifestyle modifications too. The best results come when you have surgery and diet and exercise together. Okay? I don't want to be misinterpreted about this. This surgical weight loss works, and I strongly recommend that patients consider it. There's a lot of baggage out there about it. People say, I can do it on my own, I have the power. Guess what? You can't do it on your own. Try, but let's have a plan for the next step, because your health is more important than your ego, right? We have to get this weight under control, and that's what we do. All right. So that's what I wanted to go over with you. I hope that was useful. If you have any questions, post them online, contact me separately, and we can chat about them.